Very good afternoon to everyone. I am Dr. Aditi JOSHI. I am pleased to present our study on long-term surgical outcomes in stage 4 and stage 5 ROP. So ROP is a major cause of preventable blindness. Surgery remains the only treatment option for advanced cases of ROP, specifically stages 4 and 5. But what happens to these eyes in the long term, that's what we aim to evaluate. So the purpose of the study was to evaluate both anatomical and functional outcomes of surgical treatment of stage 4 and stage 5 ROP over a minimum follow-up period of 5 years. So this was a retrospective chart review conducted at our center over a 13-year period from 2006 to 2019. 6 different operating surgeons had performed these surgeries. We collected data on patient demographics, surgical details, final anatomical and visual outcomes. We classified anatomical success into 3 categories. Unconditional success was defined as a fully attached retina with an undistorted posterior pole, whereas conditional success included cases where the posterior pole was attached but still had some residual detachment or distortion. Failure was characterized as total retinal detachment or macular detachment. So a total of 84 eyes with average duration of follow-up of 9.27 years were included in our study. 63% were males, rest were females, 40% were bilateral cases. 61% of our sample size had a stage 4 ROP at the time of surgery, rest were all stage 5, while 40% of these eyes were pre-treated with laser, 17% were treated with a combination of a laser with injection anti-VEGF. In stage 4A ROP, the primary surgical approach was lens-sparing vitrectomy, followed by scleral buckle. For stage 5, majority, that is 31 out of the 33 eyes, underwent lensectomy with vitrectomy. Now, coming to the anatomical success, it's important to highlight that the eyes classified as unconditional success at 4 to 6 weeks post-operatively largely maintained their status at the last follow-up several years later. However, eyes which initially had conditional success in the early post-operative period were more likely to experience long-term failure over time. In stage 4A ROP, the anatomical success was achieved in over 95% of the cases at 4 to 6 weeks post-op, and this remained relatively stable at 88% at the final follow-up. However, in stage 5 ROP, the success rate declined significantly over time, dropping nearly to half in the long term. The p-value was also significant in these cases. Among cases with unconditional success, the stage 4B had the best logmark visual acuity, suggesting that vitrectomy may play a role in normalizing the posterior pole. In contrast, scleral buckle, which was primarily performed for stage 4A, may not offer the same advantage in posterior pole normalization. The visual acuity was also on expected lines, with stage 5 having the worst visual outcome. There are 3 eyes in stage 4A who had good anatomical result but no functional vision due to comorbidities like optic atrophy and severe developmental delay. The best Snellen's visual acuity was 618 in stage 5 and 4B, while it was 69 in stage 4A. So we studied the long-term results in ROP since the success in the immediate post-operative period does not always sustain later in the age. The growth of the eye along with the growth of the child has a differing effect on the retina. Also, longer the duration of retinal detachment, greater is the retinal contracture. This issue was seen in stage 5 having nearly 50% chances of failure in the long term. Stage 4A and B had a better long-term stability post-surgery, mainly due to the fact that surgery is done quite earlier in life and the retinal thinning is not as much as in stage 5. Hence, the surgery for stage 4A should be done early to avoid progression to stage 5. So concluding remarks are stage 4A are amenable to buckle in significant number of cases. Stage 5 results are uniformly bad. Despite initial success, recurrence in stage 5 is an issue. However, even with 30% chance of anatomical success, it is worth an attempt, especially in bilateral situations. These are the limitations that it was a single center study, a small sample size with multiple operating surgeons. These are my references. Thank you.
Thank you. Dr. Manisha,
So thank you for the data that you've shared on ROP surgeries. I was just wondering, I mean, this is something we already know, that stage 4A, they do very well with the buccal, and stage 5, vitrectomy is the only choice, but the results are not. So I want to understand that after having done this analysis of your data, were there any additional observations that you made from the data?
These observations, ma'am, are very similar to some of the studies that have already been published. But this study has a 9-year average follow-up, which is not found so much in literature. Most of the studies are like 3 years or maximum up to 5 years. So 9 years is quite a long follow-up.
So if you had such a long-term follow-up, did you make any additional observations of a long-term follow-up of a ROP child who underwent a surgical intervention?
No new observation that we could
Right.
get.
Thank you.
Thank you.
Achha, just I wanted to know for myself, supposing a child comes with stage 4A, 4B or stage 5, so what finally we should give the prognosis to the child? Whether we operate or we don't operate, because as she has said, even after 9 years, everything becomes same. So what we should...
I think, sir, stage 4A, they do very well with the buckles. And I think they are able to be at least having an ambulatory vision, if not better. But stage 5, we have seen that very few, even if initially the retina appears well attached, the visual prognosis is bad. And many of them will have a recurrent retinal detachment.
Half the cases in
Half
our
of the
study
cases,
had,
exactly.
over time they had a...
Yes. So I think the key is that, you know, you avoid a RD, do an early screening and manage them with anti-VEGFs and laser.